You can hear us. Okay. Great. So, yeah, thanks so much for joining, guys. My name's Dan Horrocks. I work for Health Connect. I'm the person responsible for all customer introductions. So I'll be your initial MC before kindly handing the microphone to Obi. So today we're pulling back the curtain on what actually wins contracts, straight from the people who decide. So joining us, we've got Professor Craig Harris. He is the Chief Commissioner and COO at ICB Lancashire and Cumbria. He is one of the most senior commissioning voices in the NHS. So Craig, thanks so much for joining. We also have Obiajulu Okwonkwo. She is the founder and CEO of HSCT. She's a former frontline care leader who's sat exactly where many of you guys are sitting right now. Obi actually has her own AI-driven platform that helps care providers win more work. So she works in this world every day. So we're incredibly lucky to have both of these amazing people with us. Thank you for joining, Obi. In terms of how today works, we'll be running for roughly an hour. We'll move through 4 topic areas in a conversational style, no death by PowerPoint. We'll be covering how to navigate the barriers that providers get. I'm just going to mute you for. Could you just mute Obi for 1 second? Sorry, I can hear myself on your mic, Obi. Thank you. We'll be covering how to navigate the barriers that stop providers getting in the room in the first place. Things that genuinely differentiate a winning bid from an unsuccessful one, and how your data and technology can do some of the talking for you, which is the part that I'll share towards the end. Given that we've got the real people in the room here, this is a great opportunity for you to ask your questions. We've collated a lot of the questions that have come in through the registration process, but in the comment section of, if you're joining us on LinkedIn, Facebook or Instagram, you'll see the comment section on the right hand side. Feel free to talk in there. Just a little bit of housekeeping before we get underway. If you're eating lunch, we fully respect it. That's absolutely fine. If you're outside in the garden because it's a nice day, there's no judgment here whatsoever. All we ask is that you tell us what you're eating, please, so we can think about what we're going to have after this. We know that a lot of you might not have sat down since 7 a.m. today, so we really, really appreciate you tuning in to us. In the background, my wonderful assistant Tanya will be filtering some of the questions to us. So if you want to send all those through on LinkedIn, we'll be looking through those. Also, if you wish to comment on how good my hair looks today or my glowing complexion, you can also put that in the comment section too, because I'll see that. So yeah. Thank you so much, guys. Again, apologies for starting a little bit late, but yeah, we're going to get straight into it. So, Obi, can I hand over to you?
Absolutely. Thank you, Dan. And I'm so excited to be doing this because this is such a timely conversation. And it's not often that you get commissioners actually engage with providers. So this is very exciting. So today's session is focused specifically on ICB commission, and I want to start by actually addressing something really important. So from the questions that we received, which is over 50, I personally noticed a very clear pattern, and that's why I wanted to address this misconception in the market. A lot of providers are approaching ICB opportunities with a local authority mindset, and the reality, which Craig will be speaking on very soon, is that they are 2 different systems. Local authorities typically commission social care services, which is often more structured and more really focused on pricing, whereas the ICB commissions more health outcomes, which means less time and task and more about impacts and outcomes. So just to set the foundation, Dan, if I may ask, could you just start by introducing your role? So when the questions start coming in, is more directed to what you actually do.
So, was that me? Sorry, Obi.
Sorry, Craig.
Craig. Okay, sorry.
Thank you, Obi. And A couple of things. So I'm Craig Harris. I'm the Chief Commissioner for Lancashire and South Cumbria Integrated Care Board. It's slightly so off-putting because I can see Obi and I can see Dan, but I don't know the audience. So it's like because of the way we've had to do this. So it'd be great to obviously get a bit of a sense from who is in the audience when we start to ask the questions. I will accept full responsibility. I'm not used to the particular platform, and my NHS organisation decided to block the platform, which I only found out about 10 minutes before. So poor Tanya and I have tried every which way, like MI5 and MI6, to get around this firewall, and we've obviously come up with this alternative solution. So apologies, it's not exactly as we initially planned. However, I will stay on a little longer because I'm conscious you'll have all set time aside, and I appreciate you're all extremely busy. So great introduction. I actually think Obi should also get some of the questions as well, so you don't just direct them to me. She's very, very experienced, very knowledgeable, and I personally would love to hear from Obi, and maybe the next time we can put Obi in the hot seat. But for today, I am here as a commissioner. I'm a of health and care services, but I am spending NHS money. And whilst the providers of those NHS services can be local authorities or independent sector providers or private providers or NHS, there is quite a lot of guidance and a regime, so to speak, for how we put our services out to tender, how we procure them, how we commission them. And I love Obi's introduction about it is for commissioning outcomes for our population. We do dovetail with local authorities commissioned services, and I know that there'll be questions about dynamic purchasing systems, and there's a whole range of questions that I get asked about the provider selection regime, which is still relatively new. It's only just over a year old, but that is the provider selection regime and the 5 different ways in which we can award contracts is really our raison d'etre. It's that we have to follow that book, really, that is giving us more freedom and flexibilities than we previously had. It means that we don't have to tender everything, which is what we did before. So competitive tendering is no longer our default. So it allows commissioners to be much more pragmatic and solution focused and flexible in relation to providers' quality, collaboration, and a whole range of things that are not just about counting the widgets and looking at the annual accounts. It gives us a greater and more broader set of I suppose rules in which we can procure health services. I also just want to bust some myths in. I very, 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 very rarely make a decision on a commission procurement. So when people, I think, assume that everything comes past me and I get the final, royal stamp of approval, it doesn't happen like that. There are layers in organisations of reviewing tender documents with panels that are independent and objective, that then go to oversight groups, that then go into particular committees for decision making, and then depending on its size will either be signed off as a proposal through a particular committee like an executive committee, or if it's over a certain value it will go to a board meeting. So for us, I think it's 50 million of the lifetime value of a contract is where our board needs to see something. And if the contract value is over 10 million on an annual basis, the board needs to trigger that procurement. So, and that's what they call is within our SWORD, our scheme of delegation for financial management. And as an officer of the organisation, I'm responsible for ensuring that the process from we're thinking about tendering or a contract's coming up for renewal, right the way through to we're either going to extend a contract or approve a contract. I am responsible as an executive for oversight, but actual decision making is either limited to parts of the system that go through multiple, I suppose, check and challenges, and then committees. So it doesn't just sit on an individual single decision making, which I think is really important for transparency and open, and sort of being clear about objectivity and us doing things within the guidance. What does it include? What do we commission? Well, we commission health services, we commission services like integrated UEC services. We'll commission services for all age continuing care, which often care providers will ask us about. We'll commission digital services. So there's a range of services. What we don't use the PSR for, the provider selection regime, is things like medical devices or cleaning or catering, non-healthcare services. So that's done separately to how we commission. So I have a number of procurements that will be ongoing. Some of them will be about GP practices. A GP is retiring. We need to look at their practice for the future. Some of it will be intermediate care. So we need an intermediate care number of beds, or a provision or a function. Some could be adult ADHD assessments. It's one of the really hot topics at the minute. And some could be how we want to jointly work with the council on nursing residential care provision. So it can be really quite broad. It can range from usually over £100,000, because under that we've got more freedom and flexibility about grants, or because we have to put everything on an NHS standard contract, we really need to make sure that we're doing, we're being proportionate in our approach. I suppose the key objectives when they brought in the provider selection regime, they wanted it to be flexible, so about collaboration, which I think all of us, who've worked in the health and care sector would say, that's absolutely the direction of travel. We want it to support the aims of the system, so not just about individuals or individual organisations, individual providers, but what's the wider system approach, that it focuses on quality, sustainability, and reducing inequalities for people. And we've really tried to reduce bureaucracy. Now, some of you will be chuckling when you're having your lunch outside now, thinking, I can't really get a sense or feeling of how people have reduced bureaucracy. But with some of the provider selection regime approaches, then we can do things faster, quicker, and more direct. So just not to bore you with the detail, because you can look at all of this online, but we can have 3 direct awards. They're called A, B, and C. It makes it easy. A is existing provider, and really is the only reasonable provider. So some of our rurality patches, due to the distance, there's a provider, there isn't any other providers, nobody wants to go to that part of the world, and therefore we see that that's the only reasonable provider. So we look at what we call a direct award A. A direct award B is a choice-based where all qualified providers are offered a contract. So the ADHD example, there could be a number of people, they meet the quality standard, we offer a range of those within a financial envelope. And C is the existing provider is satisfying the contracting, and change would not be in the public or the patient's best interest. And again, there's a range of criteria that we need to go through. Then you've got most suitable provider, which is going into the competitive element, but it's flexible. So it is, we think you're the most suitable provider because X, Y, and Z, without having to do a formal tender. Sometimes that can take longer than an actual tender by the time you've gone through everything, thinking who's the most suitable out of all of these. So that doesn't, most suitable provider isn't always necessarily, people think that that's the best one because you avoid a tender, but you give people opportunity, and sometimes it can just take longer. And then we've got what you all know and love, our competitive tender process, which, I've been doing variations of competitive tenders now for 20 years in the NHS. I've seen some good ones, I've seen some bad ones, I've seen some hilarious ones, but they come in all shapes and sizes, like every human being does. And for a long time, that was all we had. So the fact that we've got a range of different arrangements now, I think is really helpful. I know from the care sector, we talk about the sort of the dynamic payments system, etc. regardless of which framework or procurement route, we've still got to follow the PSR guidance. So even if we're doing it, we've still got to apply our guidance for PSR, which is the provider selection regime. The reason I stutter sometimes with PSR, I'm just going to be absolutely honest. So I'm a presiding justice of the peace, and PSR in court is something very different. It's a pre-sentence report before we send somebody to custody. So sometimes when I have to say what a PSR is, I'm about to say I'm going to do a report, send you to custody, rather than actually a provider selection regime. So just a little insight into the acronyms in my life. We do utilize frameworks, and we will piggyback what I call onto frameworks with local authorities. But ultimately, so we do a lot of that with digital services, and we do a lot of it with some of the framework services where we'll call off on the framework for care providers. But everything's got to be compliant with PSR. So that's one thing that people might not realise, that, well, you're using the dynamic purchasing system with Lancashire County Council, and I say, yeah, but I still need to make sure it's PSR compliant. So there's a bit of additionality there. I know we had loads of questions on, what's the secret ingredients to let us win a tender, and how do we break into commissioning, and we've sort of fallen at the final hurdle a number of times. And I'm going to be absolutely honest, there's no magic answer, because every procurement will be different. So even if you're doing GP practices, or you're doing commissioning for intermediate care beds, so you think, okay, well, it's a GP practice, it could be on an APMS contract, it could be on a GMS contract, you could have one partner, a single-handed GP, it could be multiple partners, it could be a part of a PCN, it could not be. So then the layers of complexity don't just allow you to assume that because you've won that one and you adopt the same approach and style for the next one, that it'll be automatic, because it depends on the size and scale, it depends on the value, it depends on the term of the contract, and whether it's a 3+2 years, or a 5+2 years, or a 10-year. It also depends on if it's a collaborative partnership, collegiate, alliance agreement contract. Depends if you're going to have subcontracting arrangements. All of these things are what need to feature in the discussion. Now, a good commissioner, a courageous commissioner that is commissioning for outcomes, should be having that dialogue and engagement. And so it always frustrates the hell out of me, and concerns me when commissioners aren't close to providers. How would we know what we want if we don't ask the people who are delivering the services, and who are getting the best outcome for those patients, citizens, our people? So the engagement part of it, the contact part of it, the conversation part of it, is just as important as show me your annual accounts so I know you're a viable, financial, sustainable organisation. Show me your incidents. So it's it's really important that commissioners aren't seen in these ivory towers of, I'm in County Hall in Christchurch, that nobody can come and speak to us. I engage with providers, probably, when you work it out, a day a week in my role, whether it be NHS providers, independent sector, our voluntary sector, because that's how I do what I call a temperature check. Is it what we're thinking? Is it in my strategy? Is it supported clinically or from an evidence base or research base? Is it in our direction of travel? Is it meeting the 10-year plan? Okay, how am I going to test some of that? Well, you need to ask the people. You need to ask the people who are receiving services and the people who are delivering services. So the provider commissioner split is a bit of a nonsense in some respects. It does help with delineation and clear water on decision making and objectivity, and making sure that you're not doing what maybe some people accuse some other governments of doing when they just give people loads of contracts. So does needs to be a level of due diligence. But from my perspective, I think that we absolutely, as commissioners, have a duty of care and responsibility to engage with the partners, the sector, the people on the services that we're commissioning. So I've ranted. I could talk all day on this subject, Obi. So I'm going to stop, because maybe questions might be a bit better for people, because they might get a bit more of a single answer out of me.
I absolutely love how forthcoming you are. You're just pouring out lots of intelligence, information, insights, and I'm also making mental notes as well because this is also a learning session for me too. So thank you. So I love that you said a lot. You've said a lot about the NHS or the ICBs taking a pragmatic approach, and you've mentioned the different frameworks that you use. You also mentioned the DPSs. So the first question actually is what we're calling the registration paradox, and it's an access question. So out of the over 50 questions that we received, what providers actually want to know is, whilst we're waiting for the registration, for our CQC registration process, license rather, to be completed, what can they actually be doing to demonstrate readiness to work with you? And I also love that you mentioned once a week you engage with providers. So how can providers actually find commissioners? Because there are 42 ICBs, so, and you all have different strategies. So how can providers actually find commissioners, and what should they be doing to actually prepare themselves to engage?
Yeah, so really great question. And some of that, I absolutely understand some of that, you know, we're waiting for your CQC registration, etc., etc. That doesn't mean that they're not got skills and experience that is valid and,
Exactly.
and adds value. So, but if you are wanting to tender for something that requires you to have, you know, CQC registration, then there is a timing issue, isn't there? So let's just be honest, we don't control the regulators, and if it's a regulated setting we're commissioning for, then under PSR we've got to make sure that we've got that assurance in relation to registration. But I do get that a lot. So I think from an access point of view, it slightly depends on your topic area, on your subject matter expertise, so to speak. So with mental health, we have mental health commissioners, mental health learning disability commissioners. I get a lot of just unsolicited contact on LinkedIn or emails about, can we come speak to you about that? Can we come speak to you about this? And if I was to do that, literally, I would have no time to do anything else with just the generating amount. So I try and make sure that you know, we're always respectful, especially through the NHS in responding to people. But when we have a citizens panel, we have a really great communication and engagement team. When we're doing our strategic think tanks on commissioning, I have an inclusive, open approach for people to come to attend. So if we're going through our planning cycle and we're thinking about next year and what the 10-year health plan's telling us, what our 5-year plan is, we're going to be in year 2. So you could look at our year 2 strategic commissioning plan and say, we roughly know what the ICB in Lancashire Cumbria is going to do. And we know, based on what's happened in previous years, Craig will have a series of engagement events for us to be able to participate and be included in and offer a voice for. So some of it is about a forward look, about planning, thinking what's the ICB's next year's priorities, what's also coming out. So we know what's coming out nationally is neighbourhoods, you know, neighbourhood health. So we've got pilots, we know what's happening there. And thinking, actually, where's my organization, where's the contribution we can do, and how can that fit? What I think people do, and I understand why, but it's probably not helpful, is they do a scattergun approach. So they'll try and scattergun across the entire organization. And then what you do is you miss the opportunities that would be more tailored and bespoke to you and your organization. And that's where I think engaging with commissioners in those speciality areas. So if it is delivering health and care services in a residential or nursing home setting or a home care setting, we have commissioners which would be able to say, yeah, this is, you know, pointing them in the direction of our strategy or our plan. This is what we're doing, and these are some of the events that we're going to either be doing jointly with the local authority, or so I have them with our NHS providers, I have them with the voluntary sector alliance, I have them with the independent sector and private providers, and then I do a sort of free for all, and people can join at different points. So to get the intelligence and the knowledge and to be able to ask questions, there is something about just being a bit more purposeful and intentional in what you want and where you think that you can add value, because we'll be able to help you navigate it a lot easier. Because what we get sometimes is, I'm thinking of setting up this business, and individuals might want a whole range of things to give them advice on how to do it. That's not really a commissioner job. What we can do though is say, we can see somebody's outline business plan, what they're trying to do, whether there's a gap in the market, etc., and tell them what we're going to be looking to strategically do going forward, what we're going to be looking to commission, and allow them to then shape and develop and mold what they need to do and be as a part of our ask. So part of my job is to ask the market to respond to a particular strategic intent. So
how would you ask the market? So how would
Yeah.
you, what process is it? Is it a particular platform that commissioners typically use? How would providers know exactly when you've put out a market engagement notification or something like that?
Yeah, so we do that on the NHS chest. We'll put something out to say,
Okay.
we want your views on X, Y, and Z. ICB, so when I'm doing it with ours, our comms will send it out to a range of different people, providers, partners, local authorities. It'll go through partnership alliances, if it's the voluntary sector, to say, this is going to be something we're going to ask the market about. So when we were looking for integrated urgent and emergency care services for West Lancs, we reached out to the community, we reached out to the MP, we reached out to the local hospital, we reached out to the private provider of the walk-in centres, we reached out to primary care centres, we reached out to the community services and said, this is what we're thinking. We need to do something differently. We need to think about what's happening over here with the future of Ormskirk and Southbirth Hospital. We need to think about the provision we've got and where we're up to on those contracts for walk-in centres. And we want your view on, if this is our urgent emergency care strategy, what do you think we need for West Lancs? And we got a whole range of responses back through different engagement routes, through whether it be individuals commenting on the website, whether it be people writing to us, whether it be feedback in. I did a number of public sessions, and you get a whole range of stuff. And we often do that as pre-engagement before we'll then jump into a formal procurement process. Yeah.
So does size actually matter when working with the ICBs? Because another questions that we had, the common theme was around size. So providers are concerned that perhaps maybe if they're a smaller organization, they might not be able to work with the ICB.
So I've got contract / grants that range from, I think, £5,000 in the ICB, and we're a 5 billion budget, right the way up to 900 million. So, and anything in between. So we do need to strategically commission. So the clues in the title about the strategic element, but that doesn't mean to say that we won't look at our contracts. What we're trying to do though is have a collegiate or collaborative approach. So with our voluntary sector alliance, when we wanted to do something on urgent and emergency care as a part of our what they call the capacity investment funding, so we want to build capacity and invest in urgent emergency care services over the winter, rather than doing loads and loads of little grants with people for 5,000, 20,000, we engaged with the alliance, our voluntary sector alliance, and said, here is £500,000, I can't remember the exact amount. We want you to come back with a range of offers across the patch on how people can deliver and support our urgent and emergency care pathway. So it doesn't have to be about getting people out of the hospital, it doesn't have to be about getting people before they go in the hospital, it could be about a whole range of things in relation to earlier on in the pathway, working with primary care services, working with people with particular needs, our frailty community, etc. So we can, invest there. The contracts are all smaller contracts, but we have a strategic conversation with the sector about what they can do for us and what we can do then to invest in them for the future. So size doesn't matter in that case. But if you've got so I'm also a charity chair. I've got a national charity. It's been operational for 15 years. When we were smaller, we would have to think about, well, what contracts could we bid for based on our capacity, our workforce, our ability to deploy the resources needed to deliver the interventions. Now we're, multi-million-pound organisation, multi-different geographical patches. we can shift our focus and pivot on much bigger things that we might want to procure. So a small organisation that's got a turnover of £20,000 going for a £500,000 contract isn't probably going to meet the criteria, because you're not able to demonstrate a number of elements from a financial value for money perspective. That doesn't mean that you've not got the ability or the capability or the future ambition, but it's just about being proportionate in the sort of in what you want to put yourselves forward for, really.
Because the criteria doesn't make you competitive. It just means you're allowed to be considered. And another question that we got asked was, beyond being considered, how could you, as a provider, position yourself and differentiate yourself and write a winning bid? So you have a grant of £5,000 as an example. Lots of other small providers who also want to bid for that. So what are the differentiating factors? That's one of the
So I love AI and everything that's coming through our artificial intelligence for the future. I mean, it frightens me to death in one sense, but I think it's absolutely fantastic. But sometimes it depersonalizes things, and most of us can probably look at some bids or proposals and think there's very little human touch to it. So that's not to say that I don't, and I use AI to check things all the time about, if I need to do something quickly about cross-referencing two policies and I don't need to understand the difference in something based on my clinical experience or my commission experience. But I would say, don't lose your USP. So whilst you use the tools to support you digitally and enable you to deliver, don't lose your USP. So because AI is not delivering a lot of the service we commission, they might be in some of the digital space, but a lot of it is about what we want to commission X amount of services to deliver these outcomes for this part of the population or this cohort of people or these patients. And I want to understand your USP. So why is it you over another of those? So, and that needs to be personal. And it needs to the one thing that I think people forget sometimes, and I don't know why, and I see it so often, is people say, we delivered this amount of interventions to these people in this time scale, which is absolutely fantastic. I love that. And I say, so what was the impact? What did it make a difference?
I was just going to ask, could you give examples?
People look at me like, because it's the bit that we're all here for, aren't we? But it doesn't really, if we see 10 people, 100 people, great. But we want to make sure that, and I'm a nurse by background, so I always said that every patient contact should improve the patient experience. That's been my mantra since I was a student nurse. You don't always get it right, but if that's your intention and that's your sort of value set, then you're trying to do something that improves something for other people. That's the benefit. And far too often people tell us and it is fantastic, the work they do, the numbers that they see, the reach that they've got. And I hate the term hard to reach, so it's more about they're not hard to reach, we just need to find a different way to reach them. And people describe it in brilliant ways, but then do not describe immeasurable impact. So I don't know, and I can't take a judgment on, well, I think it's probably this and it probably is this, but you need to tell us about that measurable impact, the difference that you've made, and ambition as well. So lots of people just focus on, I'm applying for this and we've done this, that should give you a good evidence base and give you confidence that we can do this. Brilliant. But I want to know, what else can you do? Or what else are you capable of doing? So they're the things that in bids, especially because I do dip in and whilst I said I don't make decisions, I love to sit on the procurement panel because it takes me right back to my roots and I'm able to roll my sleeves up and get involved and read people. And that's the thing that always starts my antenna twitching, that when somebody said, we've done all of this and this is the impact and this is how we're going to demonstrate the impact, but also this is what people have told us, and whilst we can do all this in the future, this is our ambition, this is our direction of travel, this is what we want to achieve. That gives me a full rounded picture of the USP, their ability to deliver, their capability and ambition for the future, and the impact and the measurable difference that they're making to people.
How do you do all that and still demonstrate value for money? Because sometimes outcomes is the financial aspect of it as well. Because you could easily, it's delivering good outcomes with enough revenue or cost is achievable. But then when you have to do that under constraints of certain figures, how do you do that? How can providers demonstrate value for money whilst maintaining safe staffing, quality care, and sustainability?
Yeah. So it's a really, really good question. And I say, always be honest about the money. So don't say to me, we can do all of this and not have confidence in the ability to do it all within the financial envelope. Because what you might get is you say you can do it thinking, I don't really think I can do it. And then 3 other providers come to us and say, there's no way we can do that within the envelope. We don't always get the envelope right from the outset. So, we would hope we'd done enough preparation work and planning work to get the envelope right, but there are some times when, and I've said, actually, that's just not going to be feasible. So it's about not necessarily doing it the way you've always done it either. So everyone, when they ask me this question, or lots of people ask this question, when our model is, we've got X amount of people that do this bit of the process and X amount of people that do that bit of the process, and they're all costs. And then when we add on costs on, this is where you get to. And I'll say, what we've looked at though is, do you need X amount of those people? And we're trying not to be prescriptive with people anymore on, you need so many nurses, or you need so many healthcare assistants, or you need so many social workers, and leave it up to people to be more flexible, to say, actually, if we had more freedom and we were able to use a workforce model different, and we were able to use AI and we were able to use technology, then I think that allows people now a greater degree of opportunity to think about the utilization of the envelope in a different way. But we've still got people in very traditional, old school styles of, we've always done it that way, and not necessarily thinking about where there's best practice elsewhere, where there's innovation in other parts of the system, where there's actually successes from similar providers but in different parts of the country. There's loads of learning out there. So I would say, don't just limit it to the way you've done it and always done it, especially if you're struggling within the financial envelope, because we want people to think more creatively and we want to be able to stimulate that innovation.
I love that. So what I'm hearing is, if you have a cost in mind, as long as you can defend it using best practice, even give an example from other organizations that have been successfully delivering a certain model, you can add that to your costing and defend it. So it's about operating within a certain financial constraints, is showing and demonstrating good outcomes within a certain budget. Okay. So you mentioned earlier, you've seen bids of all shapes and sizes. So what are the most common gaps you've seen between contracts that have been successful and contracts that have been unsuccessful?
People tend to fall down on finance. So for a variety of reasons, if you are part of an organization that's part of another organization, then we need transparency for everything. And people
like subcontracting, you mean?
Subcontracting, but also, if you are a part of there's a big company and you're the delivery arm. So, there's a couple of big companies that work nationally, but only have a couple of services. So one of our integrated UEC providers only provides UEC for us in Lancashire and South Cumbria, but is a part of a bigger organisation that provides loads of other things, but has its own set of accounts. Works but we also need, and they know this because we work with them now, when we're seeing any tender or bidding, I need to understand that the organisation that also governs them is of a standard in relation to financial sustainability. So, and that doesn't work for, there's lots of people that say, well, we're just a standalone limited company or we're a charity, and that's fine. But when we look at the money, because we have an algorithm, we go through a formula, we do some research in Companies House, etc. People will fall down on not disclosing things that then end up transpiring through our due diligence checks. So that open, honest, and if you're not sure, ask before you submit something, because once you've submitted it, if you then say, oh no, well, we didn't mean that, and we've gone through a process and then we've discounted at one stage, but because of the information that you've sent us. So recently had a procurement where they put on, they had a reference code for their organization. They put on the incorrect reference code on everything. So when we did the financial checks, it came back non-viable. So they were ruled out before interview stage, and they challenged it because they said, but that's not our code, but we can only go off what people tell us. So sometimes there are just checks and balances that the providers or the individuals who are bidding need to just absolutely make sure that you're not going to inadvertently, trip into a snake pit, because obviously there's a process that follows and we need to make sure it's fair and transparent for everyone. So money is a big thing, I think. And as I said earlier, not demonstrating impact is a big thing. So people tell us on everything that they're going to do or have done, but haven't told us the difference it's made or the impact it's had. And policies and procedures.
Dan is going to be telling us a bit more about impact in a minute and how we can evidence the impact very shortly.
Yeah,
so
get your policy and procedures sorted. It's not rocket science. But if they're not, then it's not going to go forwards. And I'm a bit blasé about that now, because I just think this is not new to everybody. There are certain things that we all need to make sure that we've got. So when you're doing before you press the send button to whatever platform we're using to get a bid in, just check everything and then recheck it, because little things like that just unfortunately trip organizations up.
And it's so little. So little. And just that extra 10 minutes, just checking again.
It does. It makes all the difference.
Attention to detail. It makes all the difference. Transparency and attention to detail. Just before I hand over to Dan, who's going to show us how we can evidence all that you've said. The final question that we would like to ask you about is how providers can collaborate with the ICBs and partners to meet emerging requirements like training and workforce developments.
Yeah, it's a great question. So ICBs are, as many know, going through a year of transition due to reduction in size to meet the national requirements. So you'll start to see a bit of personnel change, bit of churn, new operating models, new focus, pivoting to be strategic commissioners. And what should come as a part of that is all ICBs should follow the commissioning cycle, and the first bit of the commissioning cycle is about understanding population health intelligence data, understanding your demographics, understanding modelling for the future. To do that, you can get, the Office of National Statistics can give you some numbers, and you get some numbers from NHS England, and that's all right. That's the data crunching stuff. That's the boring stuff for me. But people give it me and they say, actually, we know this part of the population in Lancashire Cumbria is going to end up with multiple conditions by 2030 because of the aging profile. Blah blah. Fantastic. I do love all of that, but that's not my bag. But then the part of that, health intelligence, understanding your population, the population management approach, and I call it a knowledge management approach, is about provider engagement, is about engaging with our citizens and our people and our patients, is about taking all the different sources of intelligence and bringing them together and working through them and looking at the themes. So I can't speak for other ICBs, but we have a number of provider engagement sessions. So we do them for when we're establishing, as I said earlier, our strategic commissioning intentions for the next year. We do it when so we've just done it for our intermediate care strategy development. So those providers are in the intermediate care field. We've engaged with them. We're about to refresh our UEC strategy. So we'll be saying to people, if you're anywhere on that UEC pathway from going to see your GP, asking for an urgent appointment, right the way through to being in intensive care, then we want to be able to engage on that. And again, we have all published our 5-year strategic commissioning plans, so you'll be able to see what we're trying to achieve in 5 years. You dovetail that with the 10-year health plan, so you know the longer term direction of travel. That will help in knowing. And then just ask the ICBs. We've all got communication engagement leads. We've got forward planners, so we know when we're going to engage with people. There'll be some things that'll be bespoke, but be proactive in the space. Say, because I won't know, you don't know. So until somebody says to me, can you tell me when I'm going to do that? And I'm like, oh, right, well, we'll put a comms out. But if you miss the comms because you were on a holiday for 4 weeks, which would be fantastic, and you come back, then just ask us. That there's no harm in saying, when are you going to do any provider engagements? Are you going to do one on UEC? And I could say, actually, yeah, I'm going to do one in Q3 of this year. Or I'm interested in intermediate care. And I'll say, we've just done one, but let's send over your stuff and we can have a look at it, because developing the strategy and implementing it still is a dynamic process, and it takes a lot of time, and things change. So don't think the window's missed because of either you've missed an event or you've missed a meeting, and just be proactive in the space, because we're an ICB with, we'll have about 800 people in the end, and there are thousands of you out there. So, I wouldn't be afraid of dropping us an email into either comms and people drop me emails all the time. And sometimes I'll say, I'm sorry, that's not my area. And sometimes I'll forward it on to a director and say, can somebody in the team, pick this up? And in the main, lots of people in ICBs, you might not get it immediately. I'm a 24-hour kind of guy. I can't have my inbox. I have to empty it before I go to bed. So it's either gone into a to-do file or filing, but I need to respond to something or put it somewhere to respond in the morning. Some people just take longer. That's just their style. But yeah, I would just make sure that you if you want something, my nan always said, if you don't buy a ticket, you can't win a prize. And that's what I would say to everyone about procurement and commissioning.
Thank you so much, Craig. That's been really, really insightful. And please stick around, because we're going to have we're going to be answering a few of your questions in the Q&A session. I think what we've covered so far has cleared a lot of misconceptions and reframed how providers should be thinking about ICB commissioning. So I'm going to hand over to Dan to walk us through how Health Connect can actually support providers in demonstrating person-centered care, measurable outcomes, like Craig has said, and value for money. So Dan, over to you.
Thank you so much. And Craig, Obi, thanks for covering so many amazing parts there. So I get the sort of juicy sharing screen bit, which is where I feel most comfortable now. So thanks so much. For those of you that don't know me, I'm responsible for all the customer introductions and demos. So as a team, as a software group, Health Connect has two main products. On the one hand, we have OpenDoc. OpenDoc is a policy and procedure public library platform. On the other side, we have the care record system. I'm going to be focused mostly on the care record system because that's the kind of focus of today's session. And as a team, we're thinking all the time about how can we use technology to help evidence to ICBs, to commissioners, to the wider social and healthcare world that we're supporting you on that journey. So I'm going to cover four main areas in this sort of demo section, each of which correspond directly to a lot of the questions that came in. So the first one that I want to share, I'm just going to jump on now and share my screen. Can you give me a thumbs up in the chat box, which I can't see, by the way, to let me know that you can see my screen, which I'm going to be drawing on and all the rest of it. So yeah, brilliant. So this is Albert. I'm going to wind back the clock. Albert is our longest service user in the platform. He's been with us 1 year and 8 months. The thing that's unique about Health Connect is our care record system has been built from scratch. So we've never acquired other companies in order to support the software system. So the data that we have is incredibly clean and incredibly structured. The unique selling point of Health Connect is the fact that we have AI that runs through the platform. The AI that we put in place is meaningful in the sense that we get it to try and help us and assist us in doing some of the heavy lifting. And I'm going to show you a couple of examples of that in this next section. So the first thing that I want to share is about evidencing outstanding person-centered care. So Albert came to us in this case. You can see he's been with us for 1 year and 8 months. So we have built up a picture of who Albert is from his initial referral. So we know about his food allergies, we know about his medication history, we know about absolutely everything to do with Albert in here. So one of the standout features that I want to show is around the care plan. So this is quite a new aspect of the platform. So here we've got all of Albert's existing care plans. We've got some that have been submitted, some that are overdue. So on here, when I go to create, you can see right now the AI is suggesting some care plan topics. This is based on other areas within the platform picking up on data. So it could be in the daily notes, it could be in the incidents, it is reading all the time and building up a picture as to, you know, what Albert's all about. So in this case, I'm going to choose progress and future plans. So you can see here that I've got all the main sections on the left-hand side, and I can, if I want to, I can start to kind of free text all the information in there. But you can notice wherever you see the kind of very fancy sunset kind of button here, this means that AI is available. What's going to happen if I click that button is the AI in our platform, which is a native AI tool, isn't an external tool, it's our own AI, so it won't hallucinate, it won't get anything wrong, it'll never lead you down an incorrect path. It's going to look at Albert as a person, and it's going to generate, in this case, I've chosen a progress and future plans AI-driven care plan. So as I click apply suggestions, what's just happened is our AI has gone in and fetched information about the initial referral, other existing care plans, any incidents, daily notes, conditions, allergies, habits, everything. And it has given me a care plan relevant to progress and future plans. So just to be absolutely clear, because this comes up a few times, this isn't a template that's just been applied to Albert. If I did the same care plan for a different service user, the information would be considerably different. So yeah, you can see there that that I've gone in and applied that now. Now, if I want to go back a stage and I want to have a look at an existing care plan, this is one that I prepared earlier. This is a food prep one. I've also got 3 other areas where you can evidence your person-centered care vision. So in here, we've got an AI assistant. It's broken down into 3 main areas. If I want to click generate here, the AI is going to generate a paragraph that correlates all of the information in the below section here. If I'm perhaps stuck for time or I don't have as much time as I need to, I can also analyze. So this is split into 2 parts. We have a quantitative analysis and a qualitative analysis. Here it's showing me all of the care plans that are currently in place and any that are outstanding. And you can also see that the AI is looking at the quality of the care plan. Now, as you add more information about Albert in different areas of the system, it will amalgamate all of that data. Going back to what I talked about at the beginning, our AI is learning all the time. It's building up a picture of who Albert is as an individual. So you can see here that there's a number of rules and sort of evidence areas that have been identified that we need to go away and have a look at. So if I'm an RM and I want to look at the effectiveness of what's currently in place, I can go through this, and this is now my to-do list. This is my checklist. From here, I can also start to help my team put some tasks in place. So if I go to suggest tasks, what this is going to do is it's going to look at the existing care plan relevant to the food prep information here, and it's going to go through all of the things that need to be put in place for Albert's care, and then this will allow me to quite quickly add this to a task. So you can see here that there's a title, I've got priorities, I've got when this needs to be done. So this is just another way in which we can use AI to evidence the outstanding care features that we've got in the platform using the existing information. So yeah, hopefully you found that part really interesting. Going back to the second thing, which was really about evidencing value for money and proving how you use time use your time with service users, with patients, and not doing admin tasks. One of my favorite features is the AI generated summary here. So whenever, this is the most hotly used area of the platform, to be honest. So you can add a record in here, you can select a different type, you can link it to a care plan, you can link it to a risk assessment again, so it builds up a picture of what's going on. If you simply type in here and submit, it will save the information on here. Let's say, for instance, I've just come on shift, I'm looking after Albert, but I've been on holiday for maybe a couple of weeks. In that 2 weeks, there's obviously 20, maybe 30 daily notes, and I simply don't have time to go through all of them. But what I can do is I can select 14 days and I can click generate. And what the AI is going to do is it's going to go through all of those records over the last 2 weeks and generate a hot summary for me in order of importance. So it will always list the most important observations and interactions at the top. So in this case, you can see a couple of days ago, I think, there was a missed medication. So yeah, you can see all of this. You can click submit, and then you'll see the nice sort of sunset image here. This is basically what's been going on in 2 weeks. So when I'm talking to customers and they tell me that in a shift handover, they're walking to a printer, or they're like sending emails, printing off PDFs, all of that kind of craziness, we have solutionized this to try to allow you to not have to spend time doing that. Shift handovers, holidays, sickness, or if you've got staff that are on a rota and moving through quite quickly, this is a hotly used area of the platform. So so that one was about providing you with saving your time and moving away from typical admin tasks that you would typically see. So yeah. The third area that I want to share is around visibility across your service. So if I just go back to Albert for a second there, every service user inside Health Connect has a risk overview. So we also have incidents in the platform. We have a risk assessment and management plan. We call it RAMP. So there is always a risk score associated with an individual. What about if I am really, really interested in visibility across my service, and I want to see like a bird's eye view as to everybody that I look after? So here in the audit hub, I can show you the risk register. Each one of these areas is an audit that you can run at any time. We've got missed medication, risks, referrals, staff involved for training, incidents, care plans, and legal status. They're all quite self-explanatory. But if I'm a registered manager and I care deeply about exceptional visibility across my service, and I want to demonstrate that in a winning bid, then I can go into the risk register, I can pull an audit, and I can start to look at a bird's eye view as to all of my service users. So you can see here, there's a risk score for Rose Harvey. I can click on the little eye icon, and that'll take me to why this has become a medium risk and why the risk score has increased. You can see a few weeks ago, Jay, who's a dummy service user, has an extreme score with a 25 risk score. That's the highest it can be. That tells me, as a registered manager or a care manager or an owner, I need to be aware of this, so I can take some steps in making sure that that person's okay, doing a debrief with staff, that sort of thing. And so yeah, so that is this point is about evidencing visibility, that you have your finger on the pulse when it comes to your entire service rather than individual. And the final one I want to share is about outstanding governance. So this is probably my favorite feature at the moment, given the relationship with OpenDoc and with the care record system. So if you was to work with Health Connect, one of the first things that my colleague Dan and Ruth would help you with is we would start by uploading all of your policies, procedures, and guidelines into your care record system. 95% of the time when I talk to a care provider, their policies live in Google Drive, Dropbox, another policy provider. They are on a laptop, which is, you know, quite scary, or in a physical filing cabinet. We are trying really hard to connect policies and procedures at the point of care when your staff need them. So what Dan and Ruth would help you with in the first instance, assuming you worked with us, is uploading all your policies into here. Now, when I go back to our friend Albert, and well, it doesn't actually need to be Albert, it can be anybody. If I go to, in this case, let's go to Rose, and I go to create Rose a care plan. Let's say I create, it doesn't really matter. Let's just say we've created a catheter one. The AI in our platform is reading through the policies all the time, and it will categorize them. So down here, you'll see we've got policies. We are trying really hard to give you access to policies at the point in which you need them. So on the right hand side, I've got policies. If I click the little I notification, this is telling me this is how we do it at Health Connect. This is our consent to treatment and care policy guideline. If I'm doing an oral health care plan, if I'm doing a catheter care plan, if I'm doing any of those things, the platform will prompt you with the relevant policy and procedure guidance, so that we're trying to bridge the disconnect between having a system over here, having a laptop over there, and all the kind of craziness that goes with that. So this is one of my favorite features, because I hear it all the time that staff members aren't quite connected to the policies as they need to be. So yeah, if you are really interested in having your policies and your care records together at the point at which they're needed, this is obviously one of the standout ways in which you can evidence that. So I obviously would love to connect with anybody that is interested in doing a deeper dive into some of the sections that I've shared just now. I appreciate some of that was quite fast and quick, but just bearing in mind the time commitments that everybody's given. So thank you so much. And just before I kind of hand back over to Obi for Q&A, there should be a QR code on screen if you want to sort of book in and do a deeper dive session with me. I especially want to speak with anybody who may or may not be using software that maybe rhymes with flourish, frog lie dare, or abscess. I want to hear from you. So thank you very much. Yeah, over to you, Obi.
Thank you so much, Dan. I especially love the policy because in the policy, you've got the procedures as well. So sometimes when you're trying to put your bid together, or when you're trying to talk about things that are personalized to your organization, is so handy when you have access to your procedures as well as the policies as well. So we have, so this is, I believe we have one question. Tanya, if you're on this call, could you just confirm the questions that we currently have, because now we are opening the floor to receive live questions. So if you haven't already, please go ahead. Please go ahead and send in your questions. I can't see the question. So, okay. Can you hear me? Okay. Okay, so there's a question here that says, what alternative, and this is to you, Craig, what alternative internal due diligence or readiness assessments can the ICB implement to ensure high quality new providers aren't locked out of the system before they get their first clients? Okay.
So we we haven't got a specific opening and closing window. Obviously, we have just prioritised our procurements for the 26-27 financial year. Some of that is based on urgent procurements that are required due to contracts reaching their absolute maximum, and some of that is a different prioritisation due to services that need to move for a variety of other reasons. We could have had a contract notice served on us, and as I said, we've got a range that some of them are going to be GP related procurements. As I said, we've done some larger ones related to UEC. So I'll need to check whether or not, because we do have a timetable of procurements that are coming up that we've received in our executive committee. I just need to check whether or not it is available on the website, but I will look at that after this webinar.
Okay. I don't believe there are any other questions. I haven't gotten any. So I have a question for you, Craig. So with the NHS 10-year rollout plan in effect, and we know that one of the areas of focus is from hospital to community. So care providers who may be looking at either transitioning from more home care to home health, what are the sorts of things that they would need to be thinking about? Because primarily they work with the local authority and they provide needs to the community. Transitioning from home care to home health in order to be able to support the needs of the NHS, what sort of things should they be thinking about when it comes to that transition process?
Yeah, really helpful question, Obi. So you'll hear me in multiple settings talk about hospitals should now be a destination, not a default. We should send people to hospital because they need to go for a particular reason, not because there isn't the right service or alternative. So that moving upstream, left shift, there's a whole range of things we've called it over the last 20 years, but care closer to home, care in the home. Some of it from a provider perspective, trying to think about, well, what can we do? Some of it is about the digital solution offer and technology, and what can you do that is enables you to still support individuals without necessarily having. So if you look at some of our sparsity challenges that we have in South Cumbria, and people needed to support people at home, and actually do some simple tasks that could probably be monitored remotely and done, through a particular technology. Actually, if we've got individuals traveling around to people's homes, that's costly for the care provider, but also it's not the best use of time. That should not replace where somebody does need intervention and support. But I think thinking about things and opportunities. So our primary care providers, and I don't just mean GPs, I mean our primary care providers, I think starting conversations with the primary care providers, whether that be the networks. In Lancashire Cumbria, we've been doing something called the Big Conversation with Primary Care. We're looking at wanting to get a number of federations and a federated model of federations to work across a bigger patch so we can engage in a strategic conversation. But I think, depending on where you are and what you want to do, that would be really good advice for relationship building, and thinking about, well, how can you complement or even supplement some of what they're doing rather than duplicate or be in competition with. And often those primary care providers or even the hospital staff of the community are the ones that will be having contact with those individuals. There's also some things I think can be done on a speciality basis. So whilst we talk about universal healthcare for individuals, there are things that I think are more tailored to individual specialties. So depending on what sector you're in and also what your offer is, and this is where it comes back to your USP, think about that based on, okay, well, we're doing something for a particular, I'll say diabetes because I'm the heart of diabetes, but what could we offer differently for supporting those individuals? And I think that type of conversation to get into that strategic thinking space about alternatives to the future is what I would be promoting and encouraging from our providers, regardless of your size.
I love that, because at the moment there are models that exist, community models, domiciliary care, supported living,
Yep.
and then engaging primary networks, seeing synergies, because if there's a foundation already, you already have access to partners in the community, either charity organization or really strong recruitment pipeline. It might just be a case of maybe upskilling your team, but in short, I'm echoing what you're saying, having more conversations with primary care providers. That's my takeaway from that conversation. So 2 questions have come in. How are the cuts to funding impacting discharge from hospitals for people with learning disability and autism? Another money question.
Yeah, so for us, as I said earlier, hospital needs to be a destination. We have a couple of priority focuses. So discharge and what they call, which is really unhelpful term, no clinical right to reside, or we want to make sure that people who don't need to be in hospital aren't. So there's a lot of joint working with our local authorities. We need to ensure that we get the right assessments to be able to make decisions within a timely manner. And we don't want to, we've got percentage targets to say, actually, we don't want to see more than 5% of the total bed base for any individual who's clinically no right to reside, which isn't the greatest of language. There's someone, not that, often it's not that individual's issue. It's not a choice issue. It's about the right suitable alternative if they can't go home. So that's a priority for us. And obviously, we want to ensure value for money, but it's people staying in hospital because we're saying we're not going to pay for something coming out is just the wrong approach to this. We need to make sure that the needs are met. Often, though, people get frustrated and think, right, well, I found a placement, but it is extortionately expensive, and we can't then justify why you would do that. So there is often a communication that's needed to be ongoing in these situations. But for learning disabilities, this is, again, it adds another layer of priority, because we have a responsibility post from our transforming care cohort about people, learning disability individuals being in hospital beds. So for us, I know, because I normally sign off, because they're normally quite expensive packages, are at as much as we can, trying to avoid any delays for our learning disability population, because we know they are detrimentally more affected and impacted on if they stay in hospital longer, especially if they've got comorbidities or dual needs. That's not to say that they should bump somebody else, because it's often, it's not about going to a nursing home or a care home. It's often a very bespoke package for individuals. So I would hope that we in Lancashire Cumbria aren't through our financial challenges causing further delays to learning disability individuals. And I have a particular deputy director, Kate, who works for me, that covers and looks at all of this. And I have what they call a system made meeting, which is a multi-agency discharge event every 2 weeks that I chair, to keep an eye on all of our mental health and learning disability patients. So that's got exec oversight and director oversight in the intervening weeks to make sure that this doesn't happen. But if it does, then whoever asked the question, please reach out, because I would want to know, because we've spent a long time trying to get this right. It's not perfect, but it's a lot better than what it was.
Well, Craig, on that note, I would like to say thank you. Well, from my end, because I'm conscious of time.
Yes, thank you so much.
So I'm going to hand it over to Tanya or Daniel, so they could wrap up. And if anyone wants to reach out to you, should they just reach out to you directly? How would you prefer to?
Yeah,
Yeah.
don't do it on LinkedIn, I'd say, because all of a sudden I don't look at it that often, apart from when I'm sharing things, Health Connect and other things about my charity. And then I'll go and there's about 100 messages in the inbox, and because I've turned the notifications off, and I'm like, oh, people are going to think I'm really rude and disrespectful, and not so. If you reach out through the ICB, then that's probably better.
Thank you, guys. Obi,
Thank
Craig,
you.
thanks so much for committing your time to supporting everybody on this. And for those that are listening, thank you for tuning in. And yeah, there should be some comments on the right-hand side with ways in which you can connect to us. Thanks ever so much. Have a great afternoon, and we'll see you all soon. Thank you.
Thanks, everybody. Thank you, Obi. Thanks, Tanya. Thanks, Tanya. Bye.
Bye.